Well, good evening. My name is Don Keys. I oversee GME here, and I just want to welcome you guys and introduce tonight's topic. I love it when I get to talk to the residents, and I'm always fascinated about how you guys segregate yourselves. So if I'm getting it right, this is the family medicine section row, and you are out of place. You should be over there with the medicine folks. Psychiatry's taking up that row, and fellows are over here. So it is fascinating. So anyway, this is a great opportunity for you to get to know some of your other colleagues. So welcome tonight. So this is our first installment of the GME core curriculum for this academic year. So for those folks that are new to Carilion, let me just orient you to why you're here. So we started this curriculum last year. We do this quarterly. It's a 2-year cycling curriculum. It's to cover topics that the ACGME requires of all programs. So from an efficiency standpoint, we try to give everyone the same education. So I don't wear our speakers like Josh out going to 24 different programs. It is the same information for all programs, and it's my hope that you take this information and build on it within your own program. This is required education, so please get credit for being here. And the way you get credit for being here is to sign in. So the sign-in sheets are out here. If you didn't sign in, please make sure you get signed in. If your colleagues come in after Josh gets started, the sign-in sheets will be in the back, and make sure, nudge your colleague to make sure they go back there and sign in. There were some Institute of Health, the IHI modules that were pre-assigned to you guys. I took the tact of putting them out there for you, that you're an adult learners. Adult learners should know what's important and should take advantage of opportunities. I did not require them. So I hope that at least a good portion of you took advantage of those learning opportunities to learn a little bit before Josh presents, and you'll have a good knowledge base to learn more from. So Josh Clark is our speaker for tonight. Josh is our Senior Director of Patient Safety and Quality here at Carilion. Josh is a nurse by training. He's from Roanoke, went to school at Jefferson College, but then traveled and worked at large facilities such as New York Presbyterian and New York City. He's worked at UVA, and he's worked at every adult unit here in this hospital. So he has a good breadth of understanding of medical care. Josh has served also in the last 6 years in quality and has been a real leader here and a real change agent. So I really appreciate Josh giving his time to us, and welcome him tonight.
All right, good evening. Thanks for the introduction, Dr. Keys. And I've been told that if I get you guys out of here early, you give me good evaluations. I'm really striving for good evaluations, so I'll keep that in mind as we get moving here. We have 2 modules. And so I've got objectives that cover both modules, actually. So you'll get some of this today, you'll get some of this in December when we get into the more applied improvement. Today, I wanted to make this as focused for you all as I can, that would be meaningful. And so we'll spend a lot of time thinking about healthcare quality measurement. So what that means for you as providers, what that means at the national level for healthcare providers, and some of the benefits and challenges of that. We'll also be talking about systems thinking and high reliability, and eventually explaining proactive and reactive safety culture. But today, very focused on measurement. So don't be surprised, as we talk about healthcare data challenges quite a bit. But for you all, in thinking about improvement in your professions as you continue on, understanding some of these challenges with healthcare data will be really beneficial to you, because if you're not looking in the right place, if you don't have good, valid, meaningful data, then you're not really sure what your opportunity is. And if you're committing your time to try to improve something, you better be sure that it's a meaningful and valid opportunity. So just some core beliefs. So I work in a department called Clinical Advancement and Patient Safety that's overseen by Dr. Gleason. We have a couple core beliefs that we work on, and I'm going to go into a little bit more detail on these later on in the talk, but our first one is focus. One of the challenges with healthcare in general with quality is that kind of everybody's trying to fix everything at once. What we have had success in doing is prioritizing our efforts to say what's really high impact and where can we allocate resources to really drive change rapidly. How many of you have seen projects that last for 12 to 18 months and then you're really not sure if you made a meaningful impact or not? What we strive to do is get things done in 3 months and move on to the next thing if possible, and even faster if we can. Quality and safety are built. You cannot teach your way to safe, so you may be wondering why are we doing a didactic session if we can't teach our way to safe. It's important to stress that this is not saying that it's not important to be a learning organization, but how we learn and how we diagnose and identify opportunities is critical, and that's something that we'll cover more as we get into high reliability and proactive safety culture later on in our session in December. But we also have a very unique approach to this, which I'll touch on later as well. And you also may hear the term we want to be a data-driven organization. We actually strive to be our mission-driven organization and informed by data. And there's a real unique distinction here because all of you are here hopefully for a reason because you want to help people, remembering that having data that's meaningful to you, that's going to ultimately impact that mission, is important in terms of getting buy-in, doing meaningful work, and making meaningful improvement. So some of the things that are influencing healthcare today that are really driving the conversation, ever since the rapid emergence of EMRs in healthcare, there's been this element of big data, including the impact on patient care and the financial factors associated with that, and increased pressure to reduce cost. So what that has led to is quite a bit of confusion about really what the focus is, and is the focus really to improve quality or is it to reduce cost, and what is the impact of big data and how is it influencing both patient care and financial factors. So more on that. Let's start with Dr. Codman. Has anyone ever heard of Dr. Ernest Codman? This always fascinates me. Have you heard of him, Dr. Keyes? All right. So Dr. Codman is a Harvard grad, worked at Boston, worked in Boston and for the Harvard Hospital there, Mass Gen, and was really the founder of Following Surgical Outcomes. He had something he called end result cards. He tracked every patient that he operated on for 12 months after the procedure. Eventually started to do the same thing for his colleagues and eventually reported that and published it without asking their permission, which has led to him getting in quite the tiff there. But he's also was the founder of the M&M. So any of you are familiar with the M&M process, this was really the main driver of that, Dr. Codman. And you can see kind of how he kept his data there and tried to help people make sense of that. But the main reason that he was such a big supporter of following his patients' courses was so that he could learn where he had opportunity to improve and what he could do differently for each patient, but also eventually so that the consumers would know, well, this surgeon has better outcomes. And that gets into a conversation of, when you start talking about whose outcomes are better, you get into this conversation of, well, my patients are sicker than yours, right? And so that led to the birth of risk adjustment, which we'll talk about a little bit more later. Florence Nightingale is our other one there, very well known for being kind of the founder and mother of nursing practice. But what she was before she was a nurse and caring for Crimean War soldiers, she was a statistician. I'm not sure everyone knows that. Some people think she actually invented the pie chart. She did not. It was around quite a bit before her. But this is a way that she was actually demonstrating cause of mortality in the Crimean War, and people were thinking that all these mortalities were associated with, war, when primarily most of the mortalities were associated with disease and poor treatment of soldiers that were injured or just malnourished and not having good conditions. And so that helped kind of influence the course of the war. So you think of the impact of something like that and how she used the data to change the course of that. So some examples of how it's done well. There's always unintended consequences of any way that you're showing this type of data. There's many ways to argue it, and certainly Dr. Codman experienced that with his colleagues. I didn't mention it, but if you have any questions, go ahead and shout them out. I have a couple opportunities for us to interact, but if you have specific questions, feel free. So what they were really attempting to do was convert data into intelligence. And so this is kind of you see this termed in many different places of converting data into wisdom and intelligence. And what we really struggle with, especially now that we are contributing to the big data in healthcare, is making sense of it all. And so, there was a time when all the information you needed on your patient was in a binder that was about this thick, right? And that was probably before all of your time, actually, which makes me feel a little bit old. But now there's a lot more data points. You think about all of the thousands of data points, hundreds of thousands of data points you have for each patient that's contributing to the big data picture overall, and how are we using that to guide us? And so there's a big boom in artificial intelligence and machine learning that's trying to make sense of that data and get us from descriptive analytics to predictive and prescriptive analytics. But how we integrate those tools to guide you all, and I'm sure you all have mixed results in your experiences with clinical decision support. We could do a whole nother talk on that. But how that's using big data to drive those things and drive outcomes is really where the bang for the buck is. And those machines or those companies are saying that the machine learning is turning that into intelligence. But it also depends on if we get that information to you at the right time, in the right place, and the right patient. So super challenging. And this is just what some of our data looks like. We have a talk that we do called Eliminating Dark Data. And dark data is data that's generated every day in normal business operations that goes unnoticed and goes unacted upon, even though it is suggesting that there should be action that would improve the flow and output from the business. These are things that many folks could speak to because they see them frequently, but you can see the different ways in which it's presented, trying to make sense of this. Many of the times you don't see actual occurrences. So sometimes you will hear a hospital quality person like myself say, we need to get our SIR down from 1.3 to 1.1 on our C. diff occurrences. And what's that mean to you guys? If somebody tells you that the SIR is 1.3, I mean, how do you react to that? That's the same way that they measure the data for nursing. So in the national nursing database that's used called NDNQI, they measure CODIs and they measure C. diff and falls and medication errors, all using some sort of ratio, and the nurses have no idea how many occurrences they have. They're all being compared to some sort of expected benchmark. And so we see that all the time. What that means is that most of the cases, they're risk adjusted. So with our hospital being a level 1 trauma center, being a tertiary referral center, our measures get risk adjusted. But what you don't see in the C. diff data there is that, our hospital onset of C. diff can be anywhere from 40 to 60 per month. All right, and so that SIR doesn't translate that at all. And so we've committed to talking about these things using occurrences. So even when we're talking about preventable harm, what would be considered preventable harm events such as a patient safety indicator from AHRQ, as well as HAIs and other associated preventable harm. Any questions on that? All right. So risk adjustment, this gets really challenging. This is something that you all have probably already been exposed to some extent, and will be further on in your careers. There's multiple different types of risk adjustment. It always depends on, asking about the source, asking about the risk adjustment methodology so that you have an understanding of what's really driving the expected rate. Because that's when you see a risk adjustment, you will see an observed to expected ratio, and where you want to be is below 1. But there's multiple different factors that influence that. And one of the things that we like to say when we're talking about this, there's another saying as well, but one is don't seek from your data that which is not there. And primarily this means is risk adjustment is not going to give you a solid truth on how you're doing compared to someone else. There's always going to be variation. There's no true source that is replicating how we're being measured at a national level. So CMS uses a risk adjustment. The Agency for Healthcare Quality and Research uses risk adjustment. NISQIP, you can go all into the registries. They all have their own. None of them are using the same one. And so when someone says, we're outperforming you on colon resection surgeries based on this risk adjustment, you have a long conversation to have before you really can understand what the opportunity is and if they're truly being outperformed or not. Risk adjustment also rarely fully captures the acuity of patients for hospitals like ours, especially we have kind of the unique challenge of being the only level 1 trauma center around in the region. So we're taking patients from West Virginia and from Tennessee and from all across Southwest Virginia. And so when patients come to us, we take credit for those outcomes, but we don't, it's not factored in the care that they got at another sending facility. It's not factored in how long they were in, the back of an ambulance with a tech for 3 hours while they were in shock. So again, super challenging, and a lot of that is not represented in the risk adjustment. So at the national level, since the ACA was put in place in 2012, you can see some of the programs that started to really tie financial reimbursement back from Medicare and the trend of how that was increased over time. So in 2013, hospital value-based purchasing and the readmission reduction program were put in place. 2014, HAC was added on. And so you can see there, it started out being a 2% penalty max in 2013 to what we are now, 2017, 6%. And it's staying there for now. We don't anticipate that changing anytime soon. But the readmission reduction program makes up 3% of that total percentage that can penalize us. So that's 3% of our Medicare reimbursement. For CMC here, that's about $8 million at risk related to readmissions. Our most recent performance in this measure, we out of the total 3%, we got a percentage penalty of 0.46. And that equates to a little under $500,000 that we're not getting back. So pretty insignificant when you think of it that way. We could have actually taken no penalty if we had prevented 26 readmissions. So 26 readmissions, we've gotten out of the penalty and been better than 80% of the rest of the country. So there's a very narrow margin there and a lot of money on the line for 26 readmissions. So these programs factor in complications, mortality, efficiency for the hospital, how much we spend for each Medicare encounter. So you can see what the key driver for the majority of them is what? What's the main thing CMS is after? Well, is it quality? Yeah, what was that? Measurable quality? Well, yeah, we could talk about that for a long time. The main driver and what CMS is a payer. So the main thing CMS is after is reducing cost, and they see quality, improving quality as a means to reduce cost. So any type of payer that puts in a pay-for-performance program, a lot of time they mask it around quality, but the main thing they're trying to do is reduce cost. So some of the challenges we face with the programs, one is just using administrative claims or administrative data to measure quality. So you all probably have interacted with CDI or clinical documentation integrity. There's a lot of effort and a lot of cost put in by a healthcare organization to ensure that certain things are documented, because that impacts how we're reimbursed, and it also impacts that risk adjustment that we talked about earlier. So by investing more in our clinical documentation integrity and investing more in coding, we can actually highly influence our reimbursement and how we're represented publicly. And so while we're being told that we need to reduce cost, to actually try to get more back and to try to show more quality through better coding, we have to spend more money. So it's counterproductive. And even with all of that, you still have issues like what was found with the patient safety indicators. Those are measures that are endorsed by the National Quality Forum, Agency for Healthcare Research and Quality, puts these forth, and they're called patient safety indicators. We call them PSIs. And in a study back in 2016, they found that when they actually went and did concurrent chart review or retrospective chart review for those cases, that there was significant issues with the coding actually representing the care of the patient. And so this was at Hopkins. They were actually studying their performance in several of the measures where they were being presented as being, having lots of opportunity. When they got in and actually validated what happened with the case, there was a coding error that was misrepresenting over 25% of those cases. So, again, where we invest our time, is it real clinical opportunity, or is it coding, and is it opportunity for better CDI support and better documentation? One of the other challenges with these programs that you can see in this box is how timely the data is. And so nothing in these programs is more than 2 years up to date. And so how we're being measured against each other is really going back to not just 2 years, but the mortality and the readmission programs are 3-year programs. So that's data that's 2 years old, but factors in 3 additional years before that. So if we're in, right now we're in the program for 2020, that's going to have 2017, 16, and 15 readmissions in it. So it's a big measurement period. It's a long time to influence it, but it's not a real good gauge of how you're actually doing right now. And that's what's going to be publicly reported about your hospital performance. You can get down into things that are much more service line specific, like cardiology and surgery, even some of things like in FCM in terms of mammograms and if your polyps are identified in colonoscopy. So there's many of these things that are publicly reported that are meant to help consumers are very old typically. So just remember that if that's ever presented to you. So I mentioned the consumers. It's really another effort by CMS in these programs is to improve transparency of how providers are performing. So here's a couple examples of companies that are out there attempting to do this. Leapfrog is one. Hospital Compare, Health Grades, U.S. News and World Report. They all use different methodologies for how they evaluate. And so we'll talk a little bit about that. But it's interesting how it's presented to the consumer, because these are all programs that are meant to drive down cost. and again, under kind of the meaning of improving quality, and we'll see how successful that is. So consumers are used to making informed decisions, and so I want to have a little interaction here with you all. So let's pretend you live in San Francisco. It's a little bit nicer than Roanoke and not in the eye of a hurricane. You have elderly parents that live in Roanoke, and you want to make an informed decision about where they should seek their medical care. How would you go about doing that? And this actually happened to me, just so that you can try to make this as real as possible. I had a friend call me in the car visiting Delaware. His wife was having severe abdominal pain. They were kind of in between 3 hospitals, and he called me because he knew I was in quality. He said, "Hey, can you tell me which one of these hospitals is the best one to go to?" And so instinctively I started looking back at these various options here to try to give him, my best guess. But ultimately I realized in that exercise it's very difficult to do that. So I wonder if you'll entertain me for a second. Break out your phones. See if you can make a decision, assuming you know nothing about Roanoke, you know nothing about Carilion, you know nothing about our competitive hospital across the way, and just see which one you think is better. See what you can find. I'll give you just like 3 minutes. All right, go.
That's why we recommend using
I wish I could play with my gifts. You have to teach me how to do that.
Well, I'm sitting over inside of West. It looks like a West Protestant.
Yeah.
Oh, there's so many opportunities. I see that. I see that for me.
All right. Tell me what you're finding. Anybody want to share?
I just want to point out that both Google and Siri agreed that Carilion Hospital is the best one.
So did you ask them specifically?
I did.
All right. That is really actually fascinating. I'd like to know how they arrived at that answer.
I feel like that might be biased because we're actually
In it?
So maybe by
Location. Yeah, the best one for you is downstairs. Yeah. What else did you find?
Facilities, because I was thinking it's for my parents, and I was assuming that my parents weren't my age, so I just did elderly
Mhm.
Because you didn't say what we needed to look for. You said your parents need to.
All right, you got it.
So I found people that will come to their home, but she's afraid they're gonna kill her. So that's why there's Genie's elderly care. That one seems good.
So you found some, but you don't know. There's no way to rate those at all.
No.
Maybe just some reviews, like some Yelp or something.
Yeah.
What else did you find in comparing the hospitals?
It's number 4 in Virginia.
Number 4 in Virginia. That's right.
We used to be.
We were number 4. We were number 3 last year. We're number 4 this year. So it depends on which website you clicked on. Did anybody see results from the VA? Did you see anything from the VA?
So the VA's got the most stars on the Google reviews. You know, like if I were coming from Cali and I didn't know that was the VA, I might have thought, well, it's Salem, Virginia Medical Center. It's Salem.
Right. It can confuse you. So the VA doesn't have to participate in any of these programs because, they're government. So they're not trying to reduce their cost.
I found a tiny little hospital in North Carolina that has like all these health grade 5-star ratings.
Mm-hmm.
So it has 33 affiliated providers. So it's going to be this slight little tiny place.
Yeah. Very, very common scenario there. Let's just look at the big 2 in Roanoke, and we can talk about the small hospitals too. So these are updated. These are getting ready to be announced for the fall coming up. So if you were to stumble on Leapfrog, which I gave you all the answers before you started on which ones to look for, but Lewis Gale's got an A and Roanoke's got a C. So if you just accept that and stop there, then you've made your decision, right? Because you want to go with the A hospital. So U.S. News, last year we were ranked number 3 here. Rated high performing in 6 adult specialties and 9 conditions. Lewis Gale was not ranked in Virginia and rated high performing in only 1. And so if there's like some specific issues like heart failure, AMI, or hip knee that your parents are dealing with, then maybe you're now influenced to maybe send them to Roanoke Memorial. That may be a better option. So you probably saw this. If you stumbled on Hospital Compare, you saw the star ratings. And I think they've recently been updated, and Lewis Gale went up to a 4-star. So now you're like, well, so not only are they a C hospital, but they're 2-star. Lewis Gale's a 3-star. They're an A hospital. And you're starting to compile that evidence that says, all right, I think we know where we want to go. But remember, how old is this data? Because nothing on here and all of these other programs are using CMS's data, which means you're making these decisions off of data that's 2 years old. And finally, health grades. One of the other major competitors in this market. We have more patients that would recommend Roanoke Memorial Hospital, and also an award for distinguished clinical excellence. So really, you're just kind of all over the place, right? Everything is conflicting. So in terms of you as a consumer knowing nothing, you can't make an informed decision based off of what's available. And I do want to make a comment that Dr. Keys noticed a hospital that was rocking in North Carolina with a bunch of great quality scores. We actually have that scenario here. We have, in terms of patient experience, we have the best hospital in Virginia in Giles. So if you were, to search for the best experience in Southwest Virginia, you may be pointed to go to Giles. New River, one of the best outcomes for mortality and length of stay in Virginia as well. So those are things that will highly influence those scores, but consumers don't know, if they're not familiar with healthcare, what the impact of maybe going bypassing Roanoke to go to Giles with chest pain because it's a 5-star rated hospital on Hospital Compare. All right, so you can see how it can be misleading. So again, everything that's being used in those measures primarily is administrative claims data. So it's all billing and claims data that's been sent to CMS and other payers that they're trying to make sense out of and turn into quality, meaningful quality data. But not all outcomes are created equal, right? So this is a great study on prostate surgery outcomes. So your average hospital and your best hospital here. So your average hospital is running at just 1% actually lower in survival. So really that's, if you're talking about prostate surgery and you're talking 95% to 94% survival rates, it's not a deal breaker for you. And that's one of the most common things that you'll find available in terms of comparing outcomes for conditions is a mortality or a survival rate. But now look at the best hospital and things that may actually matter to the patients. And these are things that are not captured in claims data. This requires follow-up and other manual data collection that is not, we do not have the infrastructure to do at a national level. And so you can see here things that actually matter to the patient and how that type of information is not available. And again, seeing more and more of this would be great. And that's what we're striving to accomplish here, taking some steps to do that. But when you're talking about comparing national quality and you all will be compared to each other and to your peers constantly without actually factoring in these outcomes that are actually meaningful to the patients and maybe really meaningful to you. So there's a big push to go this route. It's just a challenge logistically of how to get there. And so monitoring things that really matter to the patients, and if you all are talking to your patients, you probably know things like getting back to work quickly is something that they're really after, or being able to play with their grandkids again. There's things like that that are not captured at all in administrative claims data. So just when you're being presented with that, question the source of that and question if there's anything that's more meaningful available. So I wanted to hear if some of you would share. I did this talk earlier this week and I didn't get a lot out of you, but I think that you all know specialty specific, like what really matters to you and your patient population that you're caring for, and what do you think matters to your patients the most. And I put Dr. Gleason's star rating on here without his permission because it was good. And this is something that we've just recently done just to get direct feedback. These are directly from his patients rating him. We've just turned this on for our physicians in the last 3 months or so. So every physician who has at least, I think it's 35 or 40 reviews will have a star rating. And at least that way, that's probably more informing than anything, right? Because when we go on Amazon, that's what we're looking at. What's the star rating from the reviews? So at least that's better than understanding what Dr. Gleason's Eurogyne mortality rate is. It's probably not a very meaningful measure. Oh, I just wonder, would any of you be willing to share from a specialty-specific point of view what outcomes matter to you that are likely not being represented in any of this publicly reported data? Anyone willing to share? So not complication specific, and sometimes it's not mortality or readmission or anything like that. Any thoughts? All right, it's just crickets, the same one as last time. But just think about it going forward, and really when you're having those conversations with your patients, take the time to ask them what matters to them, what are they trying to achieve out of their care, because it could influence your care for them. So just diving into what quality improvement is a little bit here, we've got to define as a formal approach to analysis of performance and systematic efforts to improve it. And there's a couple different things that we're actually going to dive into a little bit more deeper in December. really quality improvement started with Toyota in Japan and has evolved over time. And really healthcare being a very late adopter of some of these methodologies. One of the challenges with quality is that for Toyota and in manufacturing, improving quality means reducing or eliminating variation. Right, and so how often do you all deal with variation every day? I mean, every patient, every care team is different. And so it's very difficult for us to kind of engineer out that variation. Then you throw in all the different systems that you're working with, your IT systems, your human resources, how you're doing your documentation, how you're communicating with each other, and all of those challenges that are built into that. It gets really challenging and can be a daunting task to take on. And we'll talk about the importance of how high reliability organizations identify those little things that could lead to catastrophic failures that are really system failures and address that. We'll spend more time on that in December. So just ponder this quote from Sir Cyril Chandler. This was in the Lancet in '99. As medicine used to be simple, ineffective, and relatively safe. So, back in the day, you didn't really get harmed so much from the actual care that was being delivered. Probably got more harm because you got ineffective care, which is a different type of harm. Now it's complex, for the most part, very effective, and how we measure outcomes, we can see that. But the more high risk it is, and the more complex our patient population and our care environments and the different areas where care is received have gotten much more complex and high risk, and the opportunity for us to do harm to the patients has gotten much greater. So spend a little bit of time here into why is quality improvement important. This is an old slide. This is from 2000 from the Institute of Medicine. Many of you may have seen this if you're familiar with Two Eras Human and Dr. Lucian Leap and the work from the Institute of Medicine. But basically what they were trying to do, they were talking to Congress back at this time to say, hey, there is a real issue here and we need your help. You need to help us do something about this, and you need to make the public aware. And they were multiple different ways they were trying to present this in a way that it would be meaningful and it would cause a reaction, right? So there's meant to be a shock and awe factor with this slide. So what they were suggesting is 1 of every 616 encounters resulted in a death in healthcare from preventable medical error. This is not just as someone who came into the hospital and died. This is actually what they were suggesting was deaths from something like a hospital-acquired catheter-associated UTI or central line bloodstream infection. And then they put other industries, which people would associate with being really dangerous industries. And so over on the far right, you see some examples of what high-reliability organizations are, as they are performing in very high-risk environments, doing very high-risk things frequently, but are also ultra safe. They are having 1 mortality every 100,000 encounters, or in those cases, in 10 million encounters. Whenever I look at this and I see the bungee jumping thing, I think back to senior week when I did that and say, if I'd known the odds, I might not have done that. But the most impactful thing of this is that the estimate at the time when this was published was that 98,000 patients were dying of preventable medical error. Again, and this published in 2000. So this has recently been updated in BMJ 2017, and that number has risen from 98,000 to greater than 300,000, and which would make it the third highest cause of death in the United States. And so there's always, when we present this data to physicians, it generates a lot of questions. I felt the stare from the previous group, and then we got into a discussion about what's a preventable harm. associated death. But you can see how this at least generates a conversation, right? And that's what Dr. Leap and his colleagues at the Institute of Medicine were attempting to do. They also used analogies like two 747 planes crashing every day is the amount of deaths that were associated with preventable harm. So again, one of the big challenges for healthcare in terms of raising the flag that this is an issue is that ours happen one at a time in most cases, right? When we have people who die from preventable medical error, it's typically one thing, unless you hear, and you have heard of cases where there were endoscopes that were not processed correctly, infected multiple patients, and so you hear about those batches. But it's different than when you hear about a plane crash, and it's everything everyone knows about. It's all over the news, and FAA is on site immediately, and lots of publicity. We don't get lots of publicity from our deaths associated with medical error. Here's one that is just a tragic story, but also a fascinating case. This is Jessica Santillan. She was a North Carolina resident, but an illegal immigrant. So you may, if you guys are probably mostly done with school by now, but if you had any ethics courses, this case typically comes up in ethics. Because she was an illegal immigrant and she needed a heart-lung transplant, there was a surgeon who was willing to do that for her if a match came up. And there was a big fight that went all the way up into their high courts that says she should not receive that because she was an illegal immigrant. So that's the ethics portion, but in terms of the patient safety portion, this is a classic system failure where everyone thought everyone else was confirming her blood type and did not get her the correct blood type from her donor. And so ultimately the mismatch was discovered and she died the next day. And so just a terrible story, but the family sued the provider, in this case the surgeon, and actually pressed criminal charges. The hospital also reacted and fired the surgeon. The state board got involved, and ultimately they were responsible for this. But you can imagine how many layers there should be to confirm this before it ever gets to the surgeon, right? And so this was in a time, even in 2003, what we're talking about in terms of process improvement and systems thinking was not prevalent in healthcare. It's less than 15 years ago. This is another case of a patient who was recovering from a stroke, had been in the hospital for 2 weeks, and the day before she was being discharged, she suffered a critical medication error. She actually had a feeding tube that had a connection that was the same as a syringe. And so a nurse was drawing up medication that was intended to go down into the gastric tube, and because it had the same connection as the IV tubing, she put the medicine into the IV. She actually realized it almost immediately after pushing it and seeing it flow into the vein, and the patient cardiac arrested within about 30 seconds of that, and was not able to be recovered. I tell this story because this is one of our own. This one actually happened here, and it happened with a feeding tube that had essentially been outlawed by the Institute of Safe Medicine Practices 20 years prior to the event. And basically what the Institute of Safe Medicine Practices said is you should not have any type of feeding tube or any other type of route that is the same as an IV. And they knew that because these types of events were happening all the time. They had over 1,000 cases across the U.S. where this exact same thing had happened. But there was no check. When we went to a new product that was assumed to be a better product, there was no input from pharmacy, even though it's intended to give medications. And so what you may have a tendency to think right off the bat is, well, that was a really crappy nurse, right? How could a nurse mix that up? But ultimately, it was major system failure because that product should have never been in our hospital. And so you have to think about these things differently when you're thinking about why there was an unexpected outcome. It's very common for you to think about yourselves as, the clinician and the patient variables results in the outcome. But really, it's the care team's skills and all of these other systems things and how we interact with those that really drive the outcome. So as you're out and they're beating the drum about reporting events and reporting near misses, and we're going to be doing that a lot coming up this year, those systems things that didn't result in anything but eventually could or potentially could, if you're able to report that and we address that, then sometimes we can prevent things like that from happening. So any questions on that? Any comments? Is that surprising at all? Are those numbers surprising in terms of deaths of preventable harm? Do you believe it? One of the questions I got in the last session was, did I believe it? Because I see all the events, right? I see all the serious events. And it's difficult to say because I'm very familiar with the methodology of how they calculated those numbers, that I support the numbers that they arrived at. But from my experience of how often that we see preventable harm, and again, we treat the sickest patients in a 3-hour radius. So we're more likely to see complications, so I recognize that. But because we're doing this really high-risk work on really complicated patients in a patient population that doesn't have great health efficacy, it is something that we see quite a bit. And I do think nationally our numbers are probably in that 200,000 to 300,000 range. And there has been efforts by the government to support better reporting of that so that they can do better than just an estimation. And so there's some federal law now that's allowing us to share our events with organizations called patient safety organizations, which then share that with CMS so that we can have an understanding of how often things are going wrong that are actually resulting in death. So I wanted to take a moment here to talk about QI versus QA because actually when I first started quality, I was warned that when I showed up on the unit or I showed up in procedural areas that people would turn around and run away. And a lot of that is because healthcare quality historically, especially in the 80s and 90s and with the malpractice boom, was very much quality assurance. That was the approach. So what went wrong, really reacting to that. There was no kind of accepting and avoiding the blame and shame and focusing on the systems improvement opportunities. It was really who did it and making sure that they were punished. And that was often like a response given back to if it ever was talked about, given back to the family is yeah, we've taken care of the person who made that error. That won't happen again. Now it's very different. We have a very supportive culture when mistakes are made. Hopefully you all have heard of our trust team, which supports second victims, and with our patient advocates kind of being helping to navigate complex patients who are experiencing issues and really trying to get on the same side of the table, but also understand that 99.9% of our healthcare providers come to work wanting to do the best they can for their patients. So very different approach. This has really come about in the last 20 years and continues to be more and more systems focused in terms of how we influence those patient outcomes. Oh yeah, so I forgot about this. This is how we get this reputation. This is anybody know what movie this is? All right, yeah. It's like Police Academy 4 or 7 or what? I don't know. I think there was like 7 of those. So I want to talk about meaningful improvement in terms of quality improvement. I talked about, how we're focused on systems, but this is really how clinical advancement patient safety, our department here is focused on this. Wherever you guys end up, you're going to likely see, you'll see risk management, you'll see somebody who's focused on performance measurement, but you may not always see some of the things that we offer here in terms of how we approach this. So you can see our commitment to improving on those systems and process improvement opportunities, because we're it may be the only healthcare provider in the country that has applied human factors. So there's a human factors research at Cleveland Clinic and Mayo Clinic, MedStar, where they're doing tons of great human factors research in healthcare. It's really valuable, meaningful work, but they're not turning around and applying that back to their actual systems improvement opportunities in the hospital. We have several industrial engineers that work with us. These are kind of black belt trained folks who tackle really complex process improvement problems. And if you work at a big academic medical center like this one, more than likely you will see those folks, because they have been around in this profession now for 10 or 15 years at least, and now considered a staple because of the type of complex processes that we're dealing with. We also really focus on safety culture, like I talked about, in terms of how we respond when there is something wrong, and then in analytics, in terms of meaningful analytics, how we're measuring quality. I'll skip that. So going back to core beliefs, the fact that quality and safety are built and you cannot teach your way to safe. So I hope some of you have had the opportunity to meet Dr. Parker and Dr. Wolf. They are two of our PhD human factors trained folks. Dr. Parker is actually over the new sim lab, so you may have seen her there. But what happens is if we identify a complex problem in terms of how humans interact with either software or equipment or their environment, we bring them in and they will actually assess that. They can do something called usability testing, which interacts with how, or which studies how the providers interact with the equipment. An example of that, we had a near miss where we, in MRI, a patient had been inverted in the software. The tech clicked the wrong button, inverted it, and so misread on a MRI image. Due to that, we did usability studies on that and found that type of error was very common based on the design and the flow of that software, and then gave that feedback back to Siemens, who makes the MRI machine. They actually took that and improved their software, and we've improved the software here locally. So we're actually thinking about improving quality and safety not only here for our patients, but giving that feedback back to vendors and others who can make an impact nationally and internationally. So in terms of focus, this is our clinical advancement program. Again, I talked about how one of the biggest mistakes you can make is try to work on everything at once. Even in your own section, your own department, if you think about all of the things that you should be measuring, it can be really daunting. When I first became a quality director, I was at New River Valley, and I went to a nursing unit director and said, tell me your approach on quality, what your priorities are. And she pulled out a binder that was like this thick, filled with reports and policies and all kinds of stuff. And I was like, my gosh, how are you making any sense of that at all? And so what we've worked on, and hopefully you'll hear more about this year because it's fairly new, is establishing priorities for the organization. And we limit this to 2 or 3 things. We do that also at the facility level. And so this is actually something that's required by CMS. They will come in and do surveys and things, and they say, we want to see what your quality plan is, and we want to see that your board has endorsed it. We want to see that your executives have endorsed it, your physicians have had input. And so we have a system-wide or a facility-wide quality plan that has board-endorsed priorities on it. And so in the past, 18 months or so, we've been working on doing that at the department level here. So Department of Medicine, Department of Surgery, what are the priorities for the department, and really limiting that to 3 to 5 things, and then assigning all those resources that I showed you earlier in terms of we have all these statistician analytics experts, and we have PI, and we have human factors who can come in and help solve what those top priorities for the department are. And then, continuing to drill that down into the section level, into the department and unit level in the hospital and in the ambulatory environments. Last year, I guess I'm already talking about last year, this year, our priorities have been reducing readmissions, improving end-of-life practices, and diagnostic stewardship. So we are now in the process of planning for next year, obviously, as our fiscal year turns over. And so just to share with you our priorities changing just a little bit, but you will hear a lot about our efforts for opioid stewardship with the opioid crisis. We actually have just received some pretty powerful data on that shows that Carillion as a system is prescribing on average of about 1 million opioid pills per month. That surprise anybody? Now, the majority of that is happening in the ambulatory environment and is very driven by chronic pain, which is a very tough and complex problem to deal with. About 70,000 of those pills are done at discharge from Roanoke Memorial each month. And so let me just ask you to think about this. When you order oxycodone, do you ever go and change the default? Or do you? Some of you do. All right. I'm proud of you for that. Because really the easiest thing to do when you're ordering that is somebody has chosen that default for a reason, right? And you're a resident. You're just going to assume that that's the correct thing to do. A lot of times, and maybe still today, because we're actively working on this, you will see defaults for your oxy and your lower tab and other things that are 30 pills, right? Is that the one that you see the most frequently? Now, how many people go home from a very, a one-day stay, a low-risk procedure, they're in and out, they need maybe 3 or 4 pills, and they get 30. And then what happens is, their nephew comes over and sneaks in the bathroom and gets 27 pills, and they're on the street. And so we have an obviously significant problem in Southwest Virginia with opioids. But the first thing that we can do, and the quickest thing we can do, is stop prescribing 30 pills for everybody who really needs 3 or 4. So we're doing something called behavioral economics in terms of how we order that and how we're supporting that you're ordering the appropriate amount. So the default will be much lower. And if you need to do more, you'll be able to do that. But it'll be more of a process. So instead of making it harder to order the appropriate amount, we're making it harder to order more, and hopefully, making you think about it a little bit. We'll continue to focus on care transitions and continue to focus on end of life. I know many of you now have been around long enough to see the opportunities that we have just in terms of process, in terms of end of life. Like once a patient has determined their wishes, how that flows with them across multiple care transitions and across the continuum of care is really challenging in the EMR. So we worked really hard to fix that. So, we're talking about improvement in very big buckets of work, and those are those overarching organizational priorities that if you all think about how you impact care transitions, how you impact end-of-life care discussions, which, we've seen recent publications that say a good end-of-life care discussion takes an hour. So then you have to ask yourself, are physicians the right people to be doing that, right? Physicians don't have an hour to have that discussion. So healthcare, we have to think about that differently. We're thinking about that differently in terms of how we can do that better, try to take that responsibility away from the providers, because it's just not going to happen. It's not reasonable. So, one of the other things we say is, again, the definition of insanity is doing the same thing over and over again, expecting different results. And so we're really focused on doing things differently, despite, all those that have come before us saying, well, this is the way we've always done it. So this is a quality performance indicator database. I hope that many of you will be exposed to this year. It's really been introduced in the past year and has been rolled out throughout quality support roles across the organization. It's a way for us to present to you valid, meaningful data in a way that you can easily understand how you're performing and where your opportunity is. And so one here on the bottom right is what we call our safety index. And so you can see there we have a trend of how often these types of safety events are happening. You can look at this at the unit level. This is really a nursing-specific tool focused on nursing-specific indicators. But I think, just looking at that, there's some very surprising data there, right? There's some things that should require some action in terms of how many of our employees are injured by combative patients, and what are we doing about that? Look at how the average of lift, push, pull injuries we have each month. So there's an awareness problem there because the organization has invested heavily in trying to make the environment safer, provide equipment that would help eliminate those push-pull injuries. A lot of times that equipment's not utilized because it requires an extra step. And so we see people with lifelong back issues because they did not use equipment that was, a 30-second deviation from their standard practice. So just a quick way to say, oh yeah, we have an opportunity there. What are we doing about it? Because really, this kind of whole talk is about identifying opportunities, first step in quality improvement, and how complex that can be in healthcare. This is a way that, again, we're mission-driven, data-informed, trying to provide meaningful data that you can quickly assess the opportunity and take action on it. Any questions or comment on any of that? All right. I know it's getting late. So where do you guys fit into all of this? I've talked a little bit about safety culture, getting from a pathological safety culture, which is one that says, why does it matter anyway, to reactive, where you're actually doing something when something bad happens, to calculative and proactive, where you're more focused on identifying where something could go wrong than you are on reacting to things that have gone wrong. And then there's the improvement methodology. And again, we'll focus a lot more on this in December, actually do some hands-on. But there's two primary methodologies that you'll hear about. Dr. Keys and I have talked a lot about this. Carilion, over the years, has been somewhat committed to DMAIC, which stands for Define, Measure, Analyze, Improve, and Control. I think that the CLEAR program is more supportive of the PDCA, which is a little bit more simpler. DMAIC is a Six Sigma tool, so it's much more statistics-based and assuming that you have good, meaningful data. And PDCA can be more of a quick problem-solving tool. It's military-based. And so we'll introduce both. I think it's important just for you to have an idea about it. And I don't expect you to be experts on it. I wouldn't spend a whole lot of time training you how to lead an exercise in either one of these methodologies, but just knowing which one is which and which one you should use for a problem that you're trying to solve. And then based on the complexity, especially in throughout major organizations, you'll have support to help you work through that process. So in terms of the safety culture aspect, this is Dr. Joseph Hughes. He's one of our IR radiologists. He pointed out that there was an issue with transcribing of orders for IR studies and IR procedures that was creating inconsistencies and really an opportunity for a significant bad outcome or an unintended outcome. And so by identifying that, we pulled in human factors because we realized there was like 10 different forms that were being used to transcribe, and they were all different, and the critical information on each one was located in a different place. And so, we standardized that form and went to one very simple and clean form. Then we brought in process improvement to walk through that transcription process and how it ends up with the IR procedure list, and clean that process up and eliminated all the variation that we could. And so we went from seeing 6 or 7 near misses per month where we could actually have done the wrong procedure to eliminating this and not seeing any for over 6 months at the time we were last measuring it. So just a simple call to say, hey, this is happening, and then you can back off, and you don't even have to be involved at all, but just point it out. And we may come to you as a subject matter expert to seek your input on the process, but doing something simple as this and a quick call can lead to a drastic safety improvement. Or you can get more involved, and here's an example of our orthopedics department. They submitted a quality improvement project for a quality award. This follows the DMAIC improvement methodology, and you can see how involved they are. They really took this on methodically. Were kind of jumping on the problem of the opioid prescribing very early on, and are now kind of leading the way for the rest of the organization to bring those numbers down. So it really depends, I guess, how you all impact quality, how you impact patient safety. You can be as involved as you want to. I know you have super busy schedules. Some folks are just more interested in this. There's more and more masters and doctorate programs that physicians are looking at to get involved in quality or getting involved in informatics. I know several physicians here that are working on getting black belts. So the opportunity is there for you, but the most important thing that you can do to improve patient safety is if when you see something that is not working correctly or is inefficient or is a potential risk, is just to pick up the phone, call 7SAFE and report it. And you can be done with it. And it's up to the organization and our infrastructure and our improvement focus to mitigate that risk. So I'll wrap up just by sharing a quality plan and again, how you all impact outcomes and how you impact quality, whether you know it or not. You can see here we've been really focused on reducing HAIs, specifically CAUTI and C. diff, and we're really on pace to do that at a much accelerated rate than we ever have been. And you may say, well, that's still an awful lot, but when we compare to peers of similar size and similar patient population, these are the type of numbers we see. And going back to very early in my talk, you can see we're not showing, standardized infection ratios there. We're showing occurrences. So you can see we had 79 in the last year for measurement. We're on pace to end up somewhere around 50 in our CAUTI. Again, 30, 40% reductions with C. diff. And my point is that how you all impact quality is a lot of you are doing this work. You're getting those catheters out. You're focusing on appropriate culturing practices and identifying high-risk patients that could potentially readmit or could potentially need more support when they discharge. So from a global level, you are already doing a lot from a quality standpoint, more than just kind of taking care of each patient. So how you want to be involved, we can support you, and we have a great program here that supports your ability to be involved in quality improvement if you so choose. But I'm not sure it's a choice, right? Because everybody has to be involved in at least one. Depends on the program. All right, I think that's it for me. I'll take any questions. Appreciate you all being here and giving me the opportunity to share some of our work. All right, thank you.